Thank you very much, Professor Naveen, and my congratulations for this elegant conference as usual every year. And now we are going to move to the symposium sponsored by Novars. I want to thank Novars first of all for sponsoring this symposium, and may I invite my dear friend, Professor Muhammad Sabri, Professor of Clinical Oncology in Shams University, to start his presentation, and he's going to talk about the role of ribociclib in hormone receptor positive, HER2 negative advanced breast cancer, and about the survival benefit, especially in patients with high disease burden or patient with visceral disease. Professor Muhammad.
Thank you, Professor Ghani, about your presentation to me, and thank for Novars company for allowing me to share this session of achieving overall survival benefit, changing of practice step in treatment of hormonal positive HER2 negative breast cancer patients. Introducing on CD46 inhibitors plus hormone treatment over the last 10 years changes the practice actually in the human breast cancer patients. We have here the selective ribociclib is a highly selective CD46 inhibitor that decreases phosphorylation of retroblastoma gene. That gene that's arrested the cell genoid phase and preventing to progressive to G1 phase. So starting of CD46 pathway with ribociclib enhance the efficacy of existing endocrine treatment. So we are talking today about consistently superior overall survival with ribociclib means more life. In ribociclib is the only CD46 inhibitor with evidence of first 3 randomized trials, including pre and post-menopausal women, and those with visceral metastasis. In this trial, we can see Mona Lisa 7 trials, including exclusively ribociclib plus AI in the pre-menopausal women as the first line, comparing with AI, while Mona Lisa 3 trials introducing ribociclib plus fulvestrant as a first and second line treatment for post-menopausal women against fulvestrant. And lastly, Mona Lisa 2 trial, including ribociclib plus letrozole as a first line treatment for post-menopausal AI. So patients with metastatic breast cancer who are premenopausal, especially those for visceral disease, are different to treat. Most of them more aggressive tumor biology than older women, high-grade tumors, they more advanced disease presentation, and also limited 5-year survival rates after adjuvant treatment and even for metastatic disease. So young women have unique functional and psychological needs, such as managing treatment analogs, outside families, and caring of children. So there is unmet need to decide dedicated study for a premenopausal women only. In Mona Lisa 7 trial is the first only dedicated premenopausal trial among CD46 inhibitor trials. They enrolled more than 600 patients, 670 patients with a premenopausal woman with HER2 positive, hormonal positive HER2 negative, no prior endocrine treatment for advanced disease, randomized 1-to-1 randomization to receive ribociclib plus AI versus AI alone. We can see here that Cascade demonstrated rapid and sustained first-line efficacy with AI for a premenopausal woman, including those with visceral disease. We can see here that we have separation, early separation of the curve after 8 weeks of treatment. We can achieve a rapid response rate within 8 weeks of treatment. And also there is significant improvement in MPFS, 27 months against 13 months in favor of Cascade plus AI versus AI alone. Also, you can see here just a double PFS for Cascade plus AI versus AI, and also for a patient with a premenopausal woman with visceral disease, we can see that there is significant progression, improvement of progression-free survival of 23 months versus 10 months in the patient with visceral disease. Is a very intelligent and very unique result, especially when talking about premenopausal women with visceral metastasis. With ribociclib, there is significant improvement of overall survival with achievement in term analysis with a patient almost 30% risk of reduction of death from breast cancer, and still 70% of patients still survived after 42 months from start of treatment. That's why also we should highlight that Kisqali is not indicated to be concomitant use with tamoxifen because of toxicity, and also these MONALEESA-7 overall quality of survival score were improved from baseline during treatment. In the last ASCO updates 2020, MONALEESA-7 trial shows overall survival benefit in the premenopausal patients with visceral metastasis, including those with liver mets. Here in these slides, we can see that ASCO updates, last ASCO updates, their subgroups of the patients are actually 31 relative reduction of risk of death in patients with visceral disease, and actually in the right side we can see that 47% relative reduction of death for the patient with liver mets. What's about postmenopausal population? Ribociclib was based on regulatory approval was based on MONALEESA-2 trials. Yes, approval was based on MONALEESA-2 trials, pivotal phase 3 trials, first-line trial in hormonal positive HER2 patients. MONALEESA-2 trials, largest first-line AI combination study in postmenopausal women. They enrolled about 600 patients to receive ribociclib plus cortisol versus AI again alone. We have seen that Kisqali demonstrated rapid and sustained first-line efficacy with AI even in women with visceral disease. We can see here also that's a very rapid separation within 8 weeks from treatment of ribociclib plus AI in the patient upfront. The treatment was by combination of treatment. We can see that there is median PFS 25 months versus 16 months. We have 9 months improvement of median progression-free survival for these patients. And also for patients with visceral disease, again, we have 24 months of median progression-free survival versus placebo versus letrozole. What's about postmenopausal patients who progressed on AI? MONALEESA-3 trials was a phase 3 randomized trial, double-blind, placebo-controlled trial of Kisqali plus fulvestrant in the postmenopausal women. They enrolled about 700 patients, a little bit heterogeneous population of patients. They enrolled 2 subsets of patients that treatment naive, patient, and patient progressed after 1 prior hormonal treatment. They enrolled 2-to-1 randomization to receive Kisqali plus fulvestrant versus fulvestrant alone, and PFS was the primary endpoint. We can see here that MONALEESA-3 trials demonstrated rapid and sustained first-line efficacy with fulvestrant even with women with visceral disease. You can see here again that curves was become separated after 8 weeks of treatment. Was interestingly the Kisqali plus fulvestrant, the median progression-free survival not reached till now, and also compared with only 18 months for fulvestrant only. And again, the updated data published in last ASCO, there is improvement of 33 months overall survival, median progression-free survival for the patient receiving Kisqali plus fulvestrant versus fulvestrant alone. With Kisqali, statistically significant improvement in overall survival was achieved in term analysis with 28% reduction of deaths, and also 16% of patients receiving Kisqali plus fulvestrant are still survived after 42 months of follow-up. MONALEESA trial demonstrated also rapid sustained first-line efficacy with fulvestrant in women with visceral disease. You can see here that's also time to first subsequent chemotherapy. is a very important issue in our slide here, is to postpone chemotherapy as much as possible, because many patients eventually will go for chemotherapy. By using CD46 inhibitor, you can postpone time to chemotherapy. Here in these slides, we can see that 30% reduction of time to chemotherapy was achieved with Kisqali plus fulvestrant versus fulvestrant alone. Also, the quality of survival. MONALEESA-3 trials overall quality of survival score were maintained from baseline during treatment. In last ASCO updates, MONALEESA-3 trials shows overall survival benefit in postmenopausal women with visceral and disease, especially with liver mets. We can see here that there is 20% reduction of deaths in the vessel disease and 38% reduction of the risk of death for the liver mets. So our overall survival remains the gold standard for demonstrating a clinical benefit. Also, an improvement in overall survival is a direct clinical benefit for the patients. What we are now here in the quality of survival, not survival only. As overall survival data are merged, additional measures are needed to assess quality of life. And actually, we are going now to qualify the survival. Not every patient is receiving the same treatment, and also we can maintain your treatment without no toxicity. So in the ASCO Cancer Research Committee defined incremental improvement of hazard ratio of overall survival of more than 20% over standard therapy as clinically measured outcome. We can see here in the although is a comparison cannot be done across trials, but we can go for to see this positive overall survival was 28%, 29% in the MONALEESA-7, and 27% was achieved in the MONALEESA-3 trials, and also from NARC2 trials 24%, while in PALOMA-3 they failed to achieve this value. So talking about ESMO guidelines about magnetic clinical benefit, a standardized, generic, and validate approach to certify the magnetic clinical benefit that can be anticipated from anti-cancer therapies. The European Society of Medical Oncology denoting that there is a scoring for the benefit of the drug. In these scoring factors that are taking account in the ESMO scoring, that we should take a quality of life, toxicity, and actually overall and opportunity benefit, and also prognosis of the condition. The cost is not mentioned in these because heterogeneity of the finance. So the first step is to clarify that we should have a strength of randomization evidence, and step 2, threshold for the hazard ratio and primary endpoint, and step 3 is severe hypertoxicity. We are in the non-curative intent, so our scoring between 4 and 5. In the last ABC, highlighted ESMO updates of scoring of the survival for the use of CD46 inhibitors across many agents. We can see that ribociclib plus in the premenopausal women plus AI have a score of 5, while ribociclib plus fulvestrant in the postmenopausal women has score of 4 of quality of survival. Take home message: Kisqali offer quality of survival for hormonal positive, HER2-negative advanced breast cancer patients. MONALEESA-7 trial is the first and only dedicated premenopausal trial among CD46 inhibitor trials. The combined data of MONALEESA-3 and 7, approximately 1,400 patients, represents largest body of evidence of overall survival benefit for any CD46 inhibitor. This demonstrates a consistent, manageable prolongation of survival with Kisqali with multiple endocrine agents. There was overall survival benefit with Kisqali in patients with visceral disease consistent with overall population. Rapid sustained first-line efficacy seen in women with visceral disease, even with liver mets only, within 2 years of median PFS. Thank you.
Thank you, Professor Muhammad, for this nice and summarized presentation. I'm checking the Q&A icon. Till now, no questions. We have 5 minutes for any questions. My comment, Professor Muhammad, and my question at the same time, what do you prefer if you have a patient with visceral metastasis, hormone receptor positive, HER2 negative, with visceral metastasis, regarding pre or post menopause, which selection, either to go for chemotherapy or to start with CDK inhibitors? And the second notes or second comment, which CDK, because we have some data about visceral disease improvement with abemaciclib, and now we have new data regarding ribociclib. Which do you prefer?
I think issue of chemotherapy now is postponed for a patient with vessel disease. It should be given only with patient with vessel crisis, because one of the main option of the all trials is time to postpone chemotherapy. So I think chemotherapy should preserve it only for with patients with visceral crisis. Although we have a lot of data about Molise 2 and 3 and 7 and Monarch 2 and Paloma, there's significant benefit in concerning progression-free survival and overall survival in the patient with vessel disease. So as if you postpone chemotherapy and rendering a very positive quality of life for the patient receiving hormonal treatment, you should go for this. Upon selection between different CD46 inhibitor, I think there is no predictive markers to use even ribo over abema or palbociclib. But I think if you have a premenopausal woman, you should go for Molise 7 trials. You should go for ovarian castration plus ribociclib. If you have PR negative patients, you can go for abemaciclib for subgroup of patients as Monarch 2 trial. I think for Paloma 3, my preferences is palbociclib may be suitable for elderly patient over 70. I think this is my selection between different ages of CD46 inhibitor, but by the text and by clinical trials, there's no predictive markers to use agent over agent.
Okay, thank you, Dr. Muhammad. I didn't find any other questions in the Q&A icon. And so we thank Professor Muhammad Sabri. And now we can move to Professor Ahmad Hassan, Lecturer of Clinical Oncology at Shams University. Welcome, Dr. Ahmad, and he is going to talk us tell us about one of the most interesting items regarding targeted therapy in breast cancer, regarding PI3 kinase inhibitors. I think we have some presentations in the last conference last year, and for me personally, I was so interested in, and I have presentation last year about this. And now Dr. Ahmad, he is going to tell us about the data and new data about PI3 kinase inhibitors in breast cancer. Dr. Ahmad.
To thank all those who are still with us after such a long day. So I'm going to be talking specifically today about metastatic breast cancer, hormone receptor positive, and I'm going to focus on PI3K inhibitor. Sponsored by Novartis. What breast cancer incidence is increasing not only in the developed countries, but it's also in the developing countries. The incidence, but we're not doing very well when specifically metastatic breast cancer. It's been with a
I think we have a problem in the connection with Dr. Ahmed.
Dr. Ahmed, could you please log out and log in again? We can wait for 1 minute. Thank you. Dr. Hani will go to a video for 2 minutes till Dr. Ahmed reconnects again.
Okay. Can we resume right now? Okay, we are back. Dr. Ahmed Hassan, are you ready?
Yes, I'm not sure if the interruption happened from my end or was it from...
Anyway, you can use Zoom now.
Okay. So we were saying that the incidence of breast cancer is increasing, and I'm just trying to share my screen. Just a second.
Okay, we can see you.
Okay, can you see it now?
But the screen not shared yet.
Okay,
Now we can see your screen.
Okay.
Click allow.
Right. So we were saying that the role of endocrine therapy has been the standard of care in treatment of metastatic hormone receptor positive breast cancer. It's been utilized since the 70s, first with tamoxifen, then moving on to anastrozole, and then in 2000s we've seen the development of fulvestrant, which also improved the outcomes. With better understanding of the biology of the disease, we were able to develop new agents like CDK4/6 inhibitors, and Professor Muhammad Sabri has just explained how they transformed the results and the survival figures in the first-line setting. But after utilizing first-line treatment, whether with endocrine therapy or with endocrine therapy in addition to CDK4/6, eventually, inevitably, resistance develops. And there are many causes for this resistance, but three of the most studied ways of resistance are at the receptor level. That is, the receptor sometimes just fires independent of the ligand, independent of estrogen. Even if you're inhibiting your estrogen production, you still have a crazy receptor that is still activated. And here comes a role of something that breaks down the receptor, like fulvestrant. We also learned about the ESR1 mutation, and finally, or most recently, the PI3K mutation. PI3K mutation actually is not a rare mutation. It is positive in 40% of hormone receptor positive breast cancer. So if you can think about it, it's even more prevalent than HER2 receptor overexpression, and also, of course, more common than BRCA mutation. And we've known from several studies that this actually a repeated observation, not only in one study, in several studies, that the PIK3CA gene is mutated in almost 40%. So if you look at these different studies, the numbers have always ranged between 34 to 40%. So we can say roughly 40% of hormone receptor positive patients will be PIK mutated. And it's not about only being a common mutation, but unfortunately it confers aggressive features to the tumor. So the tumor becomes more aggressive, less hormone responsive, and the survival outcomes, whether progression-free survival or overall survival results, are worse if you have the PIK3CA gene mutated. If you look at this slide, for example, look only, I don't want you to look at the investigational arms of these studies. Just look at the standard arm where we're giving only fulvestrant and a placebo, whether it's a Bell study, Solar study, Paloma, or Mona Lisa. Compare the standard arm. I don't know if you can see my cursor or not, but compare the standard arm, which is fulvestrant mutant, and again, standard arm fulvestrant, but wild type. So in both arms, we're giving the same treatment, but the only difference is the gene mutation status. So you will see that the progression-free survival is much worse. This has been observed again in several studies, which tells you that bearing this mutation makes the results much inferior. This is another study, the Monarch 2. Monarch 2, whether you give abemaciclib or you don't give abemaciclib, the progression-free survival is worse if you have the gene mutation. For example, here it's 19 months, here it's 14 months if you have the mutation. In the placebo and fulvestrant arm, it's 12 months, here is 5 months. And because it is a common mutation and because it confers significant aggressiveness, it was appealing for many to study ways to target this mutation. And in fact, it is not a very new area of research. In fact, it has been studied for several years now. But the point is, the agents that were tested in prior studies were what we call the pan-PI3K inhibitors, is that they inhibited all types of PI3K. And PI3K is a gene that is available, and it has an important function signaling or having a role in playing in signal transduction in multiple organs and multiple normal tissues. So other forms of PI3K are carrying normal physiological functions. So when we use the pan-PI3K inhibitors, we also cause damage to these normal tissues. So the collateral damage decreased the overall benefit of these agents. So for example, in the Bell study or the Sandpiper study, they couldn't escalate the doses of PI3K inhibitors to significant therapeutically effective doses because of the toxicity. But what is smart here in the alpelisib, as I will show you in a second, is that it is specific inhibits only the alpha isotype of PI3K. This limits the toxicity. It still has its toxicity, but it limited the toxicity in comparison to other older PI3K inhibitors. The landmark study, which looked at alpelisib, which is an alpha-specific PIK3 inhibitor, is the SOLAR one. This is a phase 3 randomized double-blind placebo study, and the results were actually released 2 years ago. Essentially, the study looked at postmenopausal women who had a prior treatment in the first line with either an aromatase inhibitor or any sort of endocrine therapy, but not fulvestrant. Patients also, some patients have had a prior treatment with CDK4/6. So these patients were divided into two cohorts. One cohort with a mutant PIK3CA, the other cohort had a wild type PIK3CA. And within each cohort, patients were randomized to either fulvestrant alone or fulvestrant and alpelisib. And stratification was done based on presence of liver and lung metastasis versus CDK4/6 inhibitor prior treatment. The primary endpoint of the study was progression-free survival. Secondary endpoints included overall survival, response rates, and safety. These are the patient characteristics. You can have a look at the slide, but I wanted to draw your visceral metastasis, not only visceral metastasis, but a combination of lung and liver metastasis. So they were not the best quality patients. And 5% of the patients, so it was a small number of patients, had prior CDK4/6. One would be surprised why only 5% had CDK. It's a standard of care now. The thing is, this study was actually designed in 2014, and it recruited patients from 2015 to 2017. In 2014, when it was designed and when it was opened in 2015, CDK4/6 were not that common. The first results came from the Paloma, as far as I remember, by the end of 2015. So that explains why a limited number of patients had this treatment, CDK4/6 inhibitors in the first line. The primary endpoint was met, and this was published in the New England Journal in 2019. Progression-free survival improved from 5.7 months to 11 months with a quite convincing hazard ratio of 0.65. And if you look at the Forster plot, all subgroups benefit. There was a universal improvement in outcomes in favor of the investigational arm with alpelisib and fulvestrant. If you look at the patients who've had prior CDK4/6 inhibitor, they did benefit, but as I said, it was a very small group of patients. There were only 20 patients constituting 5%. So one cannot say definitely there is a benefit, but the amplitude of benefit from 1.8 months to 5.5 months tells you something. It delivers a message that it is definitely worth looking at in other clinical trials. So we have also a benefit, but the limited number of patients in the study with this treatment, the CDK4/6, was not permissive to give statistically significant results. So if you can look here at the hazard ratio here is actually better than the whole group, but because the limited number of patients, the confidence interval was quite broad. So I would expect personally outcomes in this group of patients. And we have seen some convincing results from the BILIEVE study, which is looking specifically at CDK4/6 in the first line. Then they had the PI3K inhibitor alpelisib. Few days ago in the ESMO, Fabrice André presented the overall survival results from the SOLAR study. So the progression-free survival, which is the primary endpoint, was met, and the results were released, as I said, a year ago, and now we have the overall survival data. Again, this was the design of the study, and the primary endpoint is the progression-free survival. So what he demonstrated essentially is an improvement in overall survival. And this improvement was of 8 months, and 8 months in a second-line setting is quite a big difference. However, the pre-specified cutoff for significance was a p-value of less than 0.016. And unfortunately, this was not met in the study when the p-value, which we seen in the presentation, was 0.15. This is one of the situations in which you have a very clinically significant result, but you cannot say 100% sure that this result is definitive. It's one of the situations that we've seen, for example, in the Paloma 3, when we've seen a progression-free survival improvement, but we haven't seen overall survival improvement statistically, but clinically, there was definitely an improvement in the overall survival. And the root reason for that is the design of the study. The study was designed to pick up significantly meaningful progression-free survival. This was the primary endpoint. I guess my feeling is that if the study included larger number of patients, and if it was designed to detect overall survival, it would have detected, but I cannot confirm this for sure. So definitely we will need to see further results with other studies confirming the statistical point. Overall survival improvement was again seen in most of the subgroups. The tendency for improvement was seen in most of the subgroups, maybe with the exception of the bone-only disease. And we know that fulvestrant alone does a reasonably good job in these patients. We've seen this in the Falcon study and other studies, that in bone-only disease, fulvestrant does a good job. So maybe this is the reason. Another important result was the outcomes, the overall survival results in the lung and liver metastasis. Here, the difference was quite profound, from 22.8 months to 37.2 months, with a hazard ratio this time 0.68. So this is a quite big difference in an aggressive subgroup of patients, which tells you that this drug may have a better role in this group of patients. What happened after patients progressed on alpelisib? Some patients were switched to chemotherapy, others were switched to CDK4/6, some given everolimus. So it was a cocktail of subsequent lines of treatment. But what is important, managed to push the need for chemotherapy by 8.5 months. This is very important. Many of our patients come to our clinics and say, we don't want to have chemotherapy ever, or we want to have chemotherapy, but we can have chemotherapy, but we want to delay it as much as we can. Particularly in this time of the COVID pandemic, no one wants to deliver chemotherapy. So this is a very important result, actually, the deferral or time to onset of chemotherapy. Another information which came from the results, whether the initial results from 2 years ago or the recent update from the ESMO 2020, is the toxicity. We should know and we should be careful when we use this agent. Although I said it's a more specific, more targeted, more smart PI3K inhibitor, however, it caused grade 3 or 4 toxicity in almost exactly one third of patients. And 25% of patients had treatment interruptions because of side effects. The most common side effects were hyperglycemia, diarrhea, and rash. Grade 3 or 4 hyperglycemia was encountered in 35% of patients. So you have to be very careful with that. But it is worth mentioning that those who required interruption because of hyperglycemia were not the 35%, but were only 6%, because many patients were actually managed by their oncologists, or their oncologists referred them and being extensive. And when the investigators noticed that rash is a significant problem with this agent, they actually utilized prophylaxis with antihistamines like cetirizine and chlorpheniramine, and they found a significant decrease in the risk of rash, particularly grade 3 and 4 events. And this reminds me very much with our experience with Bolero and everolimus. When we started using everolimus, when the Bolero results came out, we had a nasty stomatitis and rash, and many patients could not tolerate it, and this was the main reason it was stopped. However, with our increasing learning experience with the agent and clinical trials like the Swiss study, which showed how to manage this particular side effect, we've learned how to use it in a better way, and actually the rate of has dropped to 0%, grade 3 or 4 dropped to 0%. So we're seeing something similar here. We need more time to get more familiar with this new agent. And this is my 4 steps prescription for making this agent more palatable or safer in use. First, we need to educate our patients. We need to educate, Novartis need to educate actually the healthcare providers how to do prophylaxis, how to counsel patients on the use of this agent. Second thing, we need to use the prophylaxis as a simple prophylaxis with antihistamines, telling our patients to keep their skin well moisturized, to use creams, and to care for their hands and feet. We should provide our patients with loperamide, that is Imodium, in case they encounter diarrhea. So there is a lot of communication here that needs to be carried between the provider or the doctor in this case and the patient. We need also to have a close eye on blood sugar levels. We need to test this, the baseline up front before we start the agent, and very frequently as per the protocol during the treatment. And we need to be prompt and start management of toxicity as early as possible. By following these 4 steps, I guess finally, PIK3CA mutations have been associated with poor prognosis, endocrine resistance, and disease progression. Alpelisib is the first PI3K inhibitor to show clinical meaningful and statistical significant results in terms of progression-free survival. And in terms of overall survival, we have a very strong tendency for improvement, but this yet needs to be confirmed statistically. This is in a situation that one can say, my heart is telling me there is a survival improvement, but my mind and my critical appraisal says wait until we have statistically sound results. And there are some questions that need to be answered. In those who have not had a prior CDK, we can start alpelisib instead. We're all familiar now, or most of us are familiar, and thousands of patients have been tested in the Mona Lisa, in the Monarch, I mean, we have more confidence in CDK4/6. So who are the subgroup of patients who might benefit from alpelisib instead of CDK4/6? Is it those with visceral metastasis? But we've seen also visceral metastasis improvements with CDK4/6. So we need really some results or some data to compare the 2 agents and to tell us when we can use or exchange the 2 agents in the first-line setting. In the second-line setting, I think this agent has established its role, and we can use it particularly with the precautions and with the more knowledge of the side effects. Another challenging thing is, what if you have used fulvestrant in the first-line treatment? Dr. Sabri has just shown us the results of the Mona Lisa 3, and many of us now use fulvestrant in the first line. So what is the best partner to add to alpelisib? The data for us is use it in the second line with alpelisib. So what if you've used it in the first line setting? We don't know yet what would be the best partner. Personally, and I was talking to the Novartis team, I think I will carry on using the fulvestrant, although I don't have good evidence to support what I am saying now. Thank you very much for your time, and all questions are welcome.
Thank you, Dr. Ahmed, for this nice presentation, and thank you for updating us with this recent data regarding this hot topic, PI3 kinase inhibitors. And now, if we have 5 minutes for any questions or comments, can you please send your questions on Q&A? My comment, Dr. Ahmed, regarding this new line and new hope, of course, regarding first concern regarding the test, the availability of the test, and now the test, I know it's available not only in the tumor biopsy but also in the serum, and we know that in the SOLAR study there was a fraction of patients who underwent the test in the serum, not on the tissue biopsy. What about the sensitivity, and first, what about the availability and the cost of the test? And may ask Novartis team, of course, if they are going to make the test more available and more cheap and so on. Second, regarding the toxicity, I think these two issues are to be considered when we are using this new agent, and of course, it has a new hope for patients with metastatic breast cancer.
Well, regarding the testing, Dr. Hani, the approved method of testing for the PIK3CA mutation or the PI3K mutation is the PCR. Is it available in Egypt? It is not available in Egypt. The drug itself is not available in Egypt. Novartis are still working on that, and they said that it will be available very soon. I'm not sure if they are intending in supporting or sponsoring testing or not, but I guess they are doing or putting a lot of effort into this. Regarding testing on serum or tissue, as you said, both methods were used in the clinical study. The specificity and the accuracy of testing it on tissue was slightly superior to testing it in the blood, in serum. So it is the gold standard, but you can still utilize it. And since we've mentioned testing and the mutation, it is worth mentioning that the mutation does not change. So, and that is why the guidelines now are advising doing the mutation testing, even if you don't intend to use the agent now, if you want to use it down the line in the second or the third line setting, because the mutation likelihood will not change. So it's 40%, and studies, when they looked at testing early versus testing late, the differences were very marginal.
Yes, concerning Dr. Ahmed, thank you firstly for your elegant presentation and answering your question in the last slide about timing of PI3 kinase. All guidelines are recommended to do for testing upon second progression after CD46. My question about upfront use of fulvestrant for patients as a single agent for patient as Falcon trial and ASU-ICOC trial, you can see that many of our colleagues and daily practice using fulvestrant as upfront treatment. Do you think that if you know that truncal mutation early, you can be you can be more reluctant to go for fulvestrant as a first-line treatment, a single agent for those patients with PI3 kinase mutation, because these upfront use of fulvestrant will even block the use of alpelisib in combination, because it's in SOLAR trial it is only recommended to be combined with fulvestrant. So I think we should go revise our information about Falcon trial and use of fulvestrant is upfront treatment for the patient too early, because we will prevent the patient to receive alpelisib in combination with fulvestrant. And also, according to Bristol trial highlighted in the last ESMO, I think last ASCO, I think the main player in the game is CD46 inhibitors, disregarding the combination of treatment, either fulvestrant or AI. So I think in those patients with these mutations, we should be wise to use fulvestrant early. Do you think this
I agree, because the study here, the SOLAR 1 study, one of the exclusion criteria was prior use of fulvestrant. So we don't have evidence if you've used fulvestrant that alpelisib will retain the same benefit. I've known that there is real world data coming soon to tell us what people have done in similar situations, because we don't know. But it would be wiser, as you said, Dr. Sabri, that to better use your cards in a mannerly order. So if you have all agents to your hand, it's better to leave fulvestrant for subsequent lines of treatment.
Yes.
Okay. Any other comments or questions? And I think we are coming to the end of the session, and we thank all of you for being late to that late time in the weekend. And we thank, of course, Novars for this nice symposium. And thank all of you, and see you.
There's a question in the box, please.
Okay. Okay, can you hear me? Can you hear me? I don't know. I don't know. Okay. Okay. Any other questions? Okay, I think we are coming to the end of the session, and we are going to thank all of you for being with us to that late time in the weekend, and thanks to Professor Muhammad Sabri and Professor Ahmed Hassan. Thanks to all the organizers, and thanks for Novars, and see you in the next symposium, inshallah.
Okay, thank you, Professor Hani Abdulaziz, for doing this session, and all of my colleagues. At the end, on behalf of the organizing committee and the member in Ain Shams Clinical Oncology Department, thank all of you, all the panelists and the attendees, and organizing the company, of course. And I want to pay your attention that our conference is still continuing tomorrow and after tomorrow, inshallah. For tomorrow, it will start at 2:30. So we are waiting to see you. Thank you very much. Bye-bye.